You are welcome to my channel. Thanks for visiting. Please remember to subscribe. This presentation will be long, but I can promise you, you are going to enjoy it because you will get all the facts about a very popular medication known as warfarin. Warfarin. This is a medication that is meant to prevent clot formation. In other words, to decrease thrombosis and eventually reducing thromboembolism. This will be very useful when we are faced with sluggish blood flow. The sluggish blood flow would have led to clot formation. In cases like atrial fibrillation, atrial flutter, where the expected forceful contraction and pumping of blood will no longer be taking place, rather quivering. It's also useful when we are faced with prosthetic valves or even native valves and blood is accumulating around the valves. It is more effective in venous-related anomaly, not in arterial-related ones where antiplatelets will be better off. So it is an anticoagulant, right? You are familiar with it, you've been taking it. Without further ado, let's go and examine all the facts about warfarin. Let us examine the origin. Warfarin. Even from the name, the nomenclature. W stands for Wisconsin, A for alumni, R for research, F for foundation. The ARIN, the iron, is from coumarin, and coumarin is found in plant, where the coumarol is obtained from. This medication, I will put in summary that is a joint effort from two big countries in North America, United States and Canada. How come? Okay. In the early and mid-20th century, particularly around 1920, 21, 22, thereabout, there was a problem in North America, northern part of United States and Canada, where some animals were dying from bleeding, from minor procedures that would not kill the rest animals. So, a brilliant Canadian by name Frank Schofield, a veterinary pathologist, was the first person to give the whole world the clue that the hay from sweet clover will contain anticoagulants. That was in 1921. Nobody could figure out what that meant until 1933, when Paul Link from University of Wisconsin, you can see now how Wisconsin Alumni Research Foundation came. Okay, so from Wisconsin University, another brilliant scientist gathered his students to examine what Frank had already stated. They embarked on the journey and they discovered that the coumarol from the hay that those animals fed on, the hay of sweet clover, was responsible. So they identified the coumarol from the hay. The coumarol is from coumarin in plants. Warfarin was first registered in 1948, not for human beings, but as a pesticide to kill rodents. In 1954, approval was granted for its use as a therapeutic agent in humans. That didn't come easy. It would have cost a life. When an individual decided to poison himself with that agent that could kill other animals. Remember, rodents are also mammals. So, fortunately for the world to be, and our own generation now, the man did not die because he was given vitamin K1, the antidote. We will get into that in a bit. So they discovered that that would be helpful in treating some conditions. That was in 1954. In 1955, a former United States president was given this medication after myocardial infarction. Then it was on record that a former leader in a big country, also not in North America but in Europe, was probably poisoned with this same medication. So I've gone through this history to let us know that warfarin came into being in the 20th century, the 1920 to 1955. So a lot of scientists worked on this in the United States and Canada. Then it's been sent around the globe. And also from this history, we could find out that this is a very powerful medication that could kill. So we will use this medication wisely and effectively to prevent death, not to cause death. So go along with me and let us see how we can make use of this odorless and tasteless medication that could be dangerous. Okay, let's examine together the 8 Ds of warfarin. I decided to put this like a kind of summary of everything we're going to go through. Why is this good medication tagged as being dangerous? You will soon understand. When do we need this? The diagnosis that will warrant the use of warfarin. We will go through them. The dose, because we can't just be taking in like we are taking water, right? The duration, we will go through, because at a point we will have to withhold warfarin. At a point we have to reduce the dose. We'll go through. Diet, I have put this yellow stuff here to let you know that diet will affect this medication tremendously. Drug-drug interaction, we will go through. Those who are familiar with my channel will know that I don't usually discuss drug-drug interaction, but today I will mention some. Diseased organs, like when we are dealing with dementia, hepatic or renal failure, hyperthyroidism, even hypothyroidism, all will have effects on this medication. Now, the Kumaro antidote, vitamin K1, will also be adopted here. But that is not the only antidote that we can use when we are faced with warfarin poisoning or toxicity. So these 8 Ds will guide us through all we need to know about warfarin. Please go through the safety protocols in your own jurisdiction. Please. There is no health jurisdiction in this world that will not have the safety protocols for the use of anticoagulant, particularly warfarin and heparin. Please revise that. This is an oral anticoagulant by classification. It belongs to the class of agents known as anticoagulant and specifically oral anticoagulant. But we have intravenous warfarin as well. The agent is also known as vitamin K antagonist. Vitamin K antagonist. Why that? I will explain further. You are welcome once again. Here, when it comes to warfarin, we'll be looking for INR. When INR is high, it means we are dealing with the probability to bleed. Higher INR means higher tendency to bleed. Lower INR means higher tendency to clot. Now, we want a range that will be safe for anyone taking this medication. So the therapeutic range is 2 to 3. So 2.5 in the middle, right? But that may change under certain conditions, meaning it is not everyone that the target of INR will be 2 to 3. So in mechanical prosthetic valves or recurrent myocardial infarction, we will be fine with higher INR of 2.5 to 3.5 and 3.0 in the middle, right? First note to go through will be that we must have good doctor-patient relationship. Why that? This is the type of medication that the doctor must be ready to see the patient. It is a must. In fact, if a doctor will have to close his practice or the doctor doesn't even want to see the patient again, he or she cannot just tell anyone on warfarin to just go away and find a new doctor. No way. He or she must find a way that another doctor would have taken over before disengaging. That is it. It is the rule. So good doctor-patient relationship must continue because the doctor must be monitoring the dose, the INR, other factors in this patient. And the patient must please be cooperating with the doctor. If you don't do that, while trying to help you, this medication may end your life. Asians, I will go into details later, so I'm not going to waste your time here. We cannot give the same dose of warfarin to every other people of other races, as we'll give to Asians. No. Higher doses for others, lower doses for Asians. Why that? Follow me. I will explain in details in a bit. One major side effect when anyone is on warfarin is bleeding. Then we want to find out how is the liver doing. If the liver is bad, we'll be careful. We will go through complete blood count with platelets. I don't know why we need to say plus platelet many times. Complete blood count should be complete blood count, including platelets. But I have decided to put this here in case somebody will listen to me somewhere in the remote part of the world. Platelets, emphasis on platelets, please. Then, it is not an insult if you are asked, how old are you? Because elderly and too young will react differently to warfarin. We will need to know if there is renal disease, kidney problem, right? Is there heart failure? Is this a free person? All this will be considered while determining the dose of warfarin. Are you on certain diet? Don't worry, I will go through the list in a bit. Are you taking other medications? Don't worry, we'll review them in a bit. Because some medications, even over the counter or herbs, can alter the metabolism of warfarin that may lead to bleeding or even lead to clot formation. Now, genetics and warfarin. Someone will ask me, you just give medication, what is the business with genetics? Oh, wow, there is. The reason is that you might have read or been told or actually experienced it that when you give somebody maybe 5 milligram, another person the same age, the same condition will be given 2.5 or 3 milligram is simply because the genetic variance when it comes to these two will determine that, okay? Here, the genetic variant involving vitamin K epoxy reductase complex subunit 1 and that of cytochrome P452C9 will determine whether we give more or lower doses. So in Asians, they need lower doses because if you give higher doses, you run to more side effects in them. But don't worry, this is not the end of this story. When I reach the stage to explain mechanism of action, I will still refer to this. So if this explanation is not okay for you, wait for the mechanism of action. Warfarin could come under different brand names. The commonest one that I am familiar with is Coumadin. But some people will ask the question, is Coumadin discontinued? Well, it is true. However, it may still be available in some countries. Remember, my presentation is not restricted to a particular country. So let's go into the story about Coumadin being discontinued in some countries or not. The manufacturing company of Coumadin is Bristol Myers Squibb. The company recalled Coumadin, that is warfarin sodium for injection, as far back as 2014. That's on record, right? In fact, the same company on April 24, 2020, 3 years ago, halted the sales of warfarin sodium known as Coumadin, that is the per one, right? In United States, Canada, Latin America, and Saudi Arabia. The reason given had been that some manufacturing issues came up. So, if that is what you are familiar with, you might not be wrong. However, warfarin is still found worldwide and is still good under different brand names. All this you can pause and go through. Now, uses of warfarin. We want to be proactive. We don't even want thrombus formation at all. So for prophylaxis, the warfarin is not a thrombolytic agent. It's not a clot buster. It is meant to prevent clot formation and decrease thrombus formation, okay? When there is less thrombus formation, there will be less thromboembolism. This is pretty useful when we are dealing with sluggish blood flow. And the sluggish blood flow would have led to clot formation. So when we know that is the situation, then we go for warfarin. Like in atrial fibrillation, atrial flutter, when there's prosthetic valve, even native valve, and so on. So we use warfarin prophylactically against deep vein thrombosis, DVT. DVT could progress to pulmonary embolism or together as venous thromboembolism. So we don't want that. So we'll go for warfarin. Also in atrial fib and atrial flutter, as I said, and when there is cardiac valve replacement, we go for warfarin. Or to prevent myocardial infarction, which is heart attack, to prevent pulmonary embolism, to prevent stroke. Even when someone had already been diagnosed with myocardial infarction, we still use warfarin because we don't want a repeat of the same event. In heparin-induced thrombocytopenia, from this nomenclature, it is obvious. This individual is on heparin, now having low platelets. The first thing to be done here is bring the expert in here, the hematologist, okay? If this individual is already on warfarin, because this person will be bleeding, right? And you want to know what is responsible for this bleeding, though we have this nomenclature that it is low platelets induced by the use of heparin. Well, we still need to find out other causes of bleeding, other bleeding dyscrasia, liver problems somewhere, diet, or whatever that could have contributed. But first thing first, if this person is on warfarin and we have reached this stage, we stop warfarin, then we reverse the effect of warfarin with the help of vitamin K1. Why did I mention vitamin K1? We have vitamin K2, vitamin K3. We'll go into that later on. Then we have checked for the causes of bleeding, right? We will continue to monitor the level of the platelets. And we then use low level of heparin for a few days, about 4 to 5, until we are able to reach the therapeutic range for INR, which will be 2.0 to 3.0. At that stage, when we have reached that, we can continue with warfarin for the time that will be determined based on the decision reached with the hematologist. Okay, it could be in few months and could be longer, or until the platelet level will be normal. So because it is also a factor of whether we are dealing with thrombosis and it's still present, or the cause that warranted the use of heparin in the first place. But the focus will remain on the value of the platelets here because it is heparin-induced thrombocytopenia. And then we know when to take the warfarin off. We know when to reverse with vitamin K. We know that when we are not winning with thrombosis, we will use low level of heparin, and then we'll be monitoring the INR for the time that we'll reach 2.0 to 3.0. Then we can bring our warfarin back. Then the hematologist will also help in that regard. Other conditions where and when we will employ the use of warfarin will include when we have laboratory results with us, or physical examination is revealing, or both the laboratory and physical examination is showing us that this individual is likely forming thrombus. If that is the case, we can discuss with the specialists around and then comment, or pharmacists as well. Also in cardiology, atrial flutter, atrial fibrillation, heart attack treated Now going on, in all these conditions, we can use warfarin. When there is risk of left ventricular thrombus formation, we can use it. In DVT, to prevent pulmonary embolism, we can use it. Stroke, ischemic stroke this time, transient ischemic attack, or this person has just undergone, cardiovascular surgery and some valves have just been replaced, prosthetic valves in situ, right? Under these conditions, remember, prophylactically I've explained, in the case of heparin-induced thrombocytopenia, I've explained, then in all these conditions, we can use warfarin. Now, in life, knowing the time to do something could be pretty important in what the outcome will be. So, warfarin is good. We've seen the uses, when to use it prophylactically or for treatment and so on. But there are many conditions when we cannot prescribe warfarin. Now, I've decided to start with this because this is the list of them all that we might overlook. When we cannot guarantee that the patient that will be using this warfarin can handle himself or herself to take this medication correctly. Correctly meaning at the right dosage and at the right time. If we cannot guarantee that, might be because the individual is now mentally challenged. It's not their fault. It can happen to me. It can happen to you. You that are listening. Even if you're a physician or not, doesn't matter. Anybody can come down with, dementia at old age, or if you have genetic constitution and so on. So someone with dementia, it is difficult unless we are sure they have the supporting system, the staff, the family member who is with me today, who I'm going to hand over these, instructions on how and when to do and come for INR and everything, signs of bleeding and everything. If I can't see anybody to do that for this good grandfather, good grandmother, I may not prescribe that warfarin today until I'm able to see the staff or a family member who will be helping him or her to keep the medication away, because there's no room for this man or woman who had spent the appreciable younger age doing good things, but unfortunately, because of genetic constitution or anything, they are done now with dementia. I won't send them to the grave, then giving them warfarin. I'm not going to do that until I have seen someone who will be responsible for the administration of this medication. Secondly, the brain may be working well, no dementia, nothing, but physically challenged. They cannot open the bubble pad, they cannot do or come for the test or do everything. Then until we are able to meet social worker and somebody is ready to do that, we should not prescribe this medication. Then the question is this. So this person needs this, to live, to prevent the pulmonary embolism or repeat myocardial infarction or stroke or TIA and so on. And you are saying you're not going to prescribe it. Okay, then what I'm going to do, I will call social worker into the meeting. Let's find a way to help this person. Then I will give the medication. So the first contraindication that I will be considering is, can this man or woman administer these drugs safely? If not, I'm not going to give it. What is the way out? Let's get social worker to come in and help us. Now, Under contraindications, we include hypersensitivity. If there is history of hypersensitivity to warfarin in the past, then today, no. If this person is already bleeding or having bleeding disorders, already known, no, warfarin off the table. Recent surgery, keep it for some time. Hypertension, particularly that is not under control. The BP is off the roof there. Not right now. We'll deal with that first. Pregnancy, I will not waste your time because I'll still address it separately. Endocarditis or pericarditis, involve the cardiologist. Someone who had just been tapped, CSF tapped through lumbar puncture, not today. We'll wait for a while. Then, like where I started from, I cannot guarantee correct administration because this person is physically or mentally impaired. I will get social worker. We have to address that, get it straight, then prescribe. We've done liver function test. We've done renal function test. They are pointing to the bad end of it, particularly the liver. The liver, because that is where the metabolism is coming from, okay? Then we have to be careful. Either we give lower dose or we don't give at all, look for another anticoagulant entirely that could be safely administered. Okay, I promise that I will address pregnancy and warfarin differently. Yes. In pregnancy, no warfarin. In breastfeeding, be careful because I will get into warfarin and pediatric age group shortly. Okay. This medication is teratogenic in the sense that it can cause deformity in the unborn child. How do I mean? Warfarin in pregnancy, particularly first trimester, there's no trimester that is safe to use warfarin, okay? But it was in first trimester. The problem we're going to run into is called fetal warfarin syndrome. That will be characterized by low birth weight. The child at birth, the weight will be pretty low. They can have mental retardation throughout life. They can become blind or deaf just from the use of warfarin. And then there's something bad again that the child will live with throughout. That is obvious, musculoskeletal deformity. The bones will be deformed. The cartilage, the bones, and joints will all be affected. So they will be lagging behind in developmental milestone as per height, growth. They won't meet. So impaired growth. And of course the head will be smaller compared to their peers, microcephaly. So the best thing is not to give any pregnant woman. However, if the pregnant woman had received mechanical heart valves, PGY, the goal is to save both the unborn child or children and the mother. But if the two will likely die, we will rather save the mother who will be able to give birth to another child in future. Not letting the mother die and not sure if the child will even live and who will look after the child. So sorry for that digression. this woman is pregnant. We can't find another anticoagulant in our jurisdiction in the remote part of the world where we're working. And this woman had just come from the city after receiving mechanical heart valves, and she's pregnant. We don't want the prosthetic valve to give room for thrombus formation and thromboembolism and so on. What are we going to do? This juncture, we'll discuss with specialists. Yeah, OBGYN, hematologists, discuss with them. Because we can't allow the woman to form thrombus, embolize, and die with the pregnancy. We don't want that. So we'll discuss with specialists. There's no harm in asking for help. We'll ask for help because this is dangerous. The medication is dangerous for the child, but the mother is also at risk. So you can see. So we'll form a meeting, a forum. The patient, the spouse, family members, then the hematologist, OBGYN specialist will all talk about it. If this woman is breastfeeding and on this, because if she's not on this, there's no need to give warfarin if the situation is not so critical. Okay? Because in neonates, we don't give warfarin. Why that? You will understand later. I'm going to explain in details relationship between vitamin K synthesis in the GI that is devoid of bacteria and a child that is exclusively breastfed. That will be a problem. But don't worry, we'll get into it in a bit. So someone is breastfeeding and she needs warfarin badly. Well, we may take the risk to give it, and then maybe the child will not breastfeed or keep an eye on the child. Remember, even the child that is not ingesting warfarin from the mother, it is likely that he or she can run into what is known as hemorrhagic disease of the newborn. We'll get into that also later on. So let me leave this page for now. Okay. We classified warfarin the other time as oral anticoagulant, and I said now we know that it is possible to be given intravenously, and then we said it is vitamin K antagonist. Now, the vitamin K dependent clotting factors that will suffer will be the following. Clotting factor 2, clotting factor 7, clotting factor 9, clotting factor 10, and then some protein like protein C, S, with or without protein Z will suffer. They will become inactive when warfarin is in the system. All clotting factors are produced in the liver except 2. Those 2 that are not produced in the liver will be factor 8 and von Willebrand factor. The rest, other clotting factors, are not affected by warfarin because they are not vitamin K dependent. Meaning, these listed clotting factors will need vitamin K to become activated. When it comes to mechanism of action, we'll understand that to nurses and medical students, when someone is on warfarin and they tell us that vitamin K dependent clotting factors are suffering, it will be 2, 7, 9, and 10. And if they say which proteins will be suffering, it will be protein C, S, with or without protein Z. dosing. We're not just going to grab any patient and just prescribe the dose of warfarin 2.5 milligram, 5 milligram, as the case be, taking it every day, same time every day, and blah, blah, blah. No, it's not going to be like that. We'll consider many things. Okay? Do we have bleeding disorder or disorders here? We'll consider that. What is the race? Is this somebody from Asia? Remember, we have talked about genetic polymorphism and variants in those two enzymes. You can pause and rewind back to genetics and warfarin. Okay, liver function test. We are targeting vitamin K dependent clotting factors produced in the liver. The metabolism of this same agent is also in the liver. So, if something will happen in the house of an individual, why won't we have a robust conversation with the owner of the house to see whether there's room for the event or not? INR, we have therapeutic range. Okay, it is expected, the higher the INR, the lower the dose of warfarin. But at a particular point, though we expect the therapeutic range of 2.0 to 3.0, but in someone with prosthetic valve, the room is there that, okay, we'll be fine with 2.5 to 3.5. Consider that. The age, not too young, not going to give it to neonates, and the elderly will be careful, they're more sensitive to it. So it's not just everybody everywhere that will take the same dose. Okay, diet. Yes, I won't waste your time because I will present this separately. Diet and warfarin. Diet and vitamin K. We're getting there. Other drugs. Maybe briefly I can talk about, there are enzyme inducers. This person is on phenobarb, carbamazepine, phenytoin. This somebody who is a known, alcoholic. Sorry, I'm not insulting you. I'm just trying to tell you the truth. So we'll consider that, because if you are not those that I've just mentioned, and you are given the same dose of warfarin like someone who is not on them, we may not be getting the same outcome. The already induced enzymes will metabolize the warfarin so pretty quickly, and we have less effect. So the DVT that we don't want to progress to pulmonary embolism will eventually progress to it. But on the other hand, if we are dealing with someone on other medications like all enzyme inhibitors, has fungal infection, is on ketoconazole, has ulcer, is on cimetidine, just binge drinking alcohol. So in this case, the enzymes will be inhibited. The effect of warfarin will last longer. The individual will be tilted to warfarin toxicity or bleeding more than the same category of individual without the enzyme inhibitors. Also, we want to know if we are on other anticoagulants, some that are doctor shopping, in the regions where, remember my presentation will go anywhere in the world, right? In the regions where the record is not being kept, on other anticoagulants, you are now, before me, you want to take these today. If you are not forthcoming, if you are not sincere that you are on other anticoagulant, even low dose of warfarin might tilt you into severe bleeding, and that might be the end. Like as simple as estrogen. Someone is a female not trying to have pregnancy or postmenopausal, trying to curtail the ovulation, and you are now on estrogen containing compounds. You know what? the tendency to clot is higher. In that case, you might need higher dose of warfarin, but INR will be leading us. Now, in what form are you going to find warfarin? Remember, when we gave the classification, stated it, oral anticoagulant. So it's going to be in form of tablet for per oral use, mostly, because we can find intravenous, route also that is injectable as 5 milligram per vial. But the per oral tablets will be in these strengths, 1 to 10 milligram. Okay, and all brand names are all in similar formulations to this one here. The injection for IV route, I'm not sure if you still have it in your country or not, but BMS discontinued it, a while ago. Still on dosing, bridging with parenteral anticoagulant. I will not waste your time here because I have a separate slide, where I'm going to explain that fully. Okay, then it is advisable, okay, that we always start low. Like to those who are very sensitive or warfarin naive, we can start with 2.5 milligram if they're very sensitive. But for most people, without any special consideration, we can start with 5 milligram. I would prefer anyone that I will start with 2.5 milligram. Now, INR will be determining how we titrate, how we go up and down. INR and the dose should be titrated. For example, if the INR is less than 1.5 and the individual has no special consideration for bleeding, then we can give as high as 7.5 milligram to 10 milligram. But to those who we have special consideration for, maybe they'll be too sensitive, like Asians, elderly, children, somebody with one pathology somewhere, you can give 5 to 7.5 milligram. And we won't place them on a long time when we're just starting, just 2 to 3 days and see what is going to happen. Like I said, INR is our guide. So if the INR is between the therapeutic range of 2.0 to 3.0, we can start low. Like I said, I'll start with 2.5 milligram if no consideration. But in those with special consideration, we can go lower, okay? And all for 2 to 3 days, okay? If INR is high now, like 3.1 to 4, then even those without any issue, no problem, will go very, very low, 1.25 milligram, okay? Also not for a long time here. And to those who are very sensitive, 0.5 milligram. Everything I've stated here, please cross-check with your pharmacist, clinical pharmacologist, hematologist, or the protocol in your jurisdiction. There's nothing forcing you to strictly follow this. I'm just telling you what is expected, that not 3 people here will take the same dose. Okay. If INR is greater than 4, we will hold a warfarin until INR has dropped to 2.0 to 3.0. Then we have to keep vitamin K. The reason why I said keep vitamin K is some jurisdictions at this level greater than 4, or some will say 4.5, some will say 5, some will say 9, some will say until 10 and above level of INR, you don't give vitamin K. Well, follow what is obtainable in your jurisdiction, please. But one thing is common to every physician all over the world. When INR is greater than 4, we know we are running into trouble already. No one will continue to load that patient with more and more warfarin. Now, the controversy whether we have reached the point to reverse the effect of the warfarin with vitamin K1 or not has remained controversial. Many people will give at least the lowest dose of vitamin K per hour at this stage of 4.5 or 5, while some jurisdictions will say no. If no sign of bleeding, give nothing. Either you withhold warfarin for some few days, then check the INR again, and so on. Now, when you are dealing with a group of brilliant, talented, experienced people, then you need to be a listener, someone who listens. So, yeah, no more controversy. Follow what is obtainable in your jurisdiction. But we are running into trouble when INR is greater than 4. If where you are, you have intravenous warfarin, those that have been banned in some countries, well, if at all, you must give it, please discuss with your pharmacist, clinical pharmacologist, or hematologist. But if you call and you are unable to get them, you can give it IV push. No. You cannot give it intramuscularly or subcutaneously. No. It can only be given intravenously and slowly. Slowly for 2 minutes. 5 milligrams for 2 minutes only, please. Dosing at hour of sleep or at night. And the question some patient will ask is, why will you give me this medication at night? It's not that it's going to sedate you. That's not the reason. Warfarin is given per hour, right? Once daily, before or after meal. Okay, and then it will be written at hour of sleep. Remember, majority of the people using warfarin will not be in the hospital, where we can take the sample for INR as we choose. Remember also, warfarin is the most used oral anticoagulant worldwide. So, if we know we are going to use warfarin, and we need to know the value of our INR, then it means the lab will be involved. Okay, so that is why someone thought it wise enough, and of course, pretty wise and universally acceptable, that we should give it an hour of sleep because the lab will take the blood during the day for INR. The medication that has been given overnight will have gotten into the system before the sample for INR will be taken during the day. So the value taken during the day will most likely depict the true state or the effect of that warfarin. That is the reason why that man or woman had been given warfarin to be taken at hour of sleep. But if you are in the hospital or you are close to the lab and they are not telling you that you take it at hour of sleep, it doesn't mean that the doctor doesn't know what he's doing. It's because he or she is aware that by the time he or she will order you to take the sample or to go to the lab, or the lab people will come to take your sample for INR, it will be enough time to get the true picture of the effect of warfarin. Okay, we have reached a point, and this is very, very significant. The mechanism of action of warfarin. Before going into full info here, remember that we have also classified warfarin as vitamin K antagonist. And I have said before now that the liver is responsible for producing all clotting factors except two. And those two will be von Willebrand factor and factor 8. So the vitamin K dependent clotting factors produced by the liver will be in trouble because the vitamin K itself will be in trouble. How would that be? Warfarin will work on an enzyme called vitamin K epoxy reductase complex unit 1. Remember, under the genetics and warfarin, I have made the reference to this enzyme in Asians. So warfarin will reduce the capacity of this enzyme by inhibiting this very enzyme. This enzyme is responsible for activating vitamin K. Now that this enzyme is being inhibited by warfarin, it means vitamin K will no longer be active. If vitamin K is not active, then all vitamin K dependent clotting factors 2, 7, 9, and 10 will not be active. Hence, clot formation will become impaired. Since the vitamin K has been incapacitated by warfarin, by inhibition of the enzyme known as vitamin K epoxy reductase complex unit 1, then clot formation is not at bay or not happening at all. Vitamin K is also known to be required for the synthesis of protein C and S, and they are meant for coagulation regulation. So this effect from protein C and S is also lost once warfarin is present. You can see how powerful warfarin is. Keeping vitamin K, that is the backbone of formation of clotting factors 2, 7, 9, and 10, and also protein C and S, keeping everything at bay, inhibiting them. That is how warfarin works. You have been given warfarin. Your doctor is taking INR to know how well the medication is working, whether it's working well or not. Okay. The initial time that the effect can be noticed on INR will be the first 24 hours to 72 hours. Then we'll expect the full effect to show between the 5th to the 7th day. So we may not bother ourselves so much if we are getting now that is still subtherapeutic in the first 1 week of the onset of the use of warfarin. Now, someone may ask me, for how long should my father or grandfather be on this medication? Please, that will be determined by a physician, because I cannot tell exactly why your loved one is on this medication and other associated condition or conditions in him or her. Okay, that's it. Some people may be on it for 1 to 3 months. Like if someone has heart attack called myocardial infarction, no, out of it now, but we don't want a repeat occurrence, and you are on warfarin to prevent further clot formation. It might not be forever, okay? But it depends on some other associated conditions. Some may be on it for 2 to 3 months if what we are guiding against is left ventricular thrombus formation, but that will be determined after echo had been done and some EKG analysis and so on. Some may be on it for 3 to 6 months, particularly those with mechanical valves, and even people with mechanical valves could be on it indefinitely. Remember I said it is difficult to treat anyone by proxy. There are so many other conditions that could be contributory. And indefinitely could be the timing. If there's any word like that, it could be that the loved one will be on this medication indefinitely if he or she is having atrial fibrillation, atrial flutter, unprovoked venous thromboembolism, thromboembolic pulmonary hypertension, or as your physician may deem it fit, like mechanical valves, like I said, might be for 3 to 6 months or indefinitely. So it depends on the total condition or total health condition or conditions that warranted the use of this medication in the first place. So no two people will have the reason or reasons for using this medication and the duration the same way. Okay, you might like to listen to this. You're on treatment. You've been given warfarin, correct dose, but the INR is low, meaning it appears that we are not winning, looking as if the warfarin is ineffective. Then what could be happening? Depending on where you are on the surface of the earth, it might be fake drug. Somebody is surprised, right? Well, some that are listening to me in some parts of the world will agree with me it might be fake drug. Yeah, okay. That is ruled out. Okay, fine. There might be other drugs being used concomitantly for good reasons, but you don't know. Like you are on enzyme inducers. Like somebody is having seizure disorder and you're on phenobarb or phenytoin or even carbamazepine, then you're in trouble. Or is another part of the world where there is tuberculosis and this person is on rivampin or rifampicin, as the case may be. All these are enzyme inducers that will metabolize warfarin fastly. We induce the enzymes in the liver, cytochrome 3,450, to metabolize the warfarin faster, even before exercising therapeutic effect. It might be non-compliance. You have been told to take 1.5 or 2.5 or 5 milligram every day. But this individual that is not mentally challenged, no dementia, no physical challenge, might be willingly or inadvertently will not take it every day. Or he or she has traveled, or he or she is so busy. Anyhow, non-compliance. Diet, don't worry, I'll get into that separately very soon. But let's just say you are taking vitamin K rich foods. And remember, this medication is to find vitamin K. And then you are introducing vitamin K exogenously from outside into the system, hello, we are not likely going to win. Okay? Broccoli, spinach, don't worry, I'll get into that in a bit. Gastrointestinal tract related issues. Remember, this medication has been tagged oral anticoagulant. So it's been given per oral. But there are issues from the mouth, before it gets to the intestine and then is absorbed that could impair the absorption. And you think you've taken the medication, but it's not getting to the system. Don't worry, I will get to this very issue right now. Let's go. Now, you are on Warfarin. The INR is low. It appears preventing clot formation is not what is achievable. Don't worry. It might be gastrointestinal tract related issues only. So we need to work on that. Okay. So are we dealing with malabsorption syndrome somewhere? Is this person having diarrhea, whether acute today when you take medication, tomorrow and the following day for 3 days? Out of the 5 days you've been taking the medication, you've been having diarrhea, and then you come on the 5th day, the measure INR is not going above 1.5 that it was 3 days ago. Where's the problem? The problem is with the diarrhea. Vomiting. You've just taken the medication, not quite a few minutes after you vomited. Don't you know you would have vomited the medication alone? And some people that, not for the reasons of their own, I'm not saying malabsorption or chronic diarrhea or acute diarrhea is self-induced. No, I'm not saying that. But some people have chronic conditions. Inflammatory bowel disease, Crohn's, ulcerative colitis, impairing the capability to absorb via gastrointestinal tract. If that is the case, we need extra work, right? Some have short gut syndrome, they've done operation, resection has taken place, ascites from hepatic problem, from fluid intolerance generally, from massive renal failure, and so on, and even heart failure. All oral medications, when there's ascites or congestive cardiac failure, absorption is impaired. Yes, the emphasis on the monitoring of diet while on warfarin cannot be overemphasized. So I'm going to repeat it here again. Vitamin K rich foods will affect the effect of warfarin. How? Warfarin is meant to inactivate vitamin K so that vitamin K dependent clotting factors will not be able to come together. They will no longer be active to form clot. Clot formation prevention is what warfarin is all about. And then vitamin K will be incapacitated, will be inhibited by inhibiting the enzymes activating it. But you are bringing vitamin K from outside when the warfarin is doing that one internally. And somebody is asking me, from where? Okay, get your pen. From broccoli, from spinach, cauliflower, kale, sunflower oil, canola oil, peanut, from liver, green tea, chewing tobacco, cabbage, lettuce. You are on all those? Somebody say, no, I'm not on all of them. I'm just not taking only broccoli. And so another is saying spinach. Well, note that once you are rich in diet, rich in vitamin K, your warfarin may not work effectively. It is good to be on all these, good foods, but when it comes to the mechanism of action of warfarin, you are like using warfarin to hold vitamin K that is inside, preventing it from the liver's function of synthesizing clotting factors 2, 7, 9, and 10, protein C and S, but you are maybe inadvertently, because you didn't know, introducing the same vitamin K from outside. You are holding a family member and you are bringing a member of that family again from outside into the room. So you are not winning because of the dyes. Now let's examine vitamin K and gastrointestinal tract bacteria infection. We don't like that. Who does? Who would like infection in any part of his or body? But you know what? When it comes to vitamin K, it's a blessing in disguise. Yeah. Because vitamin K is synthesized in the presence of intestinal flora, specifically bacteria. And it is being absorbed along the gastrointestinal tract. You can see the relationship. Synthesized there by the help of bacteria, absorbed there. Remember, that is why we do have hemorrhagic disease of the newborn, because their gastrointestinal tract appears to be sterile. So they produce less of vitamin K, and then the umbilicals could start oozing out blood and so on. If there is less bacteria, either because the individual is newborn, neonates, or because we are using antibiotics, or because the individual is on exclusive breastfeeding that is pretty clean, then there will be less vitamin K production. If there is less vitamin K production, the effect of warfarin will be higher, meaning decreased vitamin K is equal to increased warfarin effect, meaning there will be increased tendency or even frank bleeding. So we don't need to waste our time too much about that. If that is the case, we can give per oral vitamin K 1 milligram to stabilize the warfarin. The role of vitamin K1 while you're on warfarin. Yes, your doctor may give you vitamin K1 per oral if he or she is monitoring the INR and is getting above 4. Some will say at 4.5. Others will say, I'm not going to give it unless he or she is bleeding. Well, some will still give maybe at least the lowest dose of vitamin K1 per oral, even if the individual is not bleeding, but INR is 4 or greater. Some won't even give any amount of vitamin K per oral unless the INR is greater than 9. Everyone should agree on one thing together. That is, we need to either stop or decrease the dose of warfarin appreciably when the INR is tending towards bleeding. Sure. And then we will all agree that we should rule out other possible bleeding disorders. If not, from trying to help this man or woman, you might be causing more harm than good. So, our liver function test will be done to know if the liver is still working well, metabolizing the warfarin, or if we have the liver that is in trouble, then we don't give so much dose of warfarin anymore. Then the renal function test will also be considered because end-stage renal disease will warrant appreciable significant dosage reduction in warfarin. Complete blood count is necessary, particularly the level of platelets, because thrombocytopenia, that is low level of platelets on its own, could trigger bleeding. Then clotting profile will help. So all these will all be done once anyone is on warfarin, because we want to be sure that it is not only INR value that is responsible for bleeding or not. So many people will say, I will not give vitamin K unless the patient is bleeding. But some of us will give once the INR is getting, off the roof, even if without seeing signs of bleeding. But all of us will do something with the dose of the warfarin, and all of us will keep an eye on the signs and symptoms of bleeding, which I'll get into right here. Now, I have told you about vitamin K1, but let me tell you, I need to bring this out clearly, that vitamin K1 is not the only one that is in existence. We have vitamin K1, K2, and K3. K1 is what we need when it comes to blood coagulation. That is why it is the one that we will give to reverse the effect of warfarin. K2 is not bad, it is good. We can find both K1 and K2 in some rich diets with vitamin K. While K1 is good today for warfarin-related coagulopathy, K2 will not serve that purpose. K2, from literature I found, that will be good for bone and heart. But I am not prescribing that right here. Don't take it. Please discuss with your doctor or pharmacist. But just to let you know that there is an entity known as vitamin K2. We don't need that for blood coagulation. We need K1. K3 is also in existence, but is known or perceived to be harmful to human beings. Vitamin K as an antidote. But let it be clear. We can just say vitamin K is the commonest used antidote to reverse warfarin effect, but it's not the only antidote. I'll get into that in a bit. At what level of INR are we going to start using vitamin K in anyone taking warfarin? Well, many people will say that they won't even give vitamin K at all unless there is bleeding. In all, we don't really give unless it is required. Most we give vitamin K when INR is 4 or greater. Like I've said earlier, some will not even give unless it is greater than 9 or reaching 10. INR is 9 or 10. But everyone will either stop warfarin for 1-2 days, check INR again, or reduce the dose, depending on the value and how scary it is. What dose of vitamin K would anyone give if the patient is on warfarin? Commonly, once it is not so scary, the severity will determine the dose. of course, and some other things we can do, which I will talk about next. So in that case, 1 to 2 milligram will be fine, with maximum about 5 milligram if it is not so scary. Okay. Then the other question will be, through what route? Is it per oral, intramuscular, subcut, intravenously? And I said, get this right. Mostly, we will give it per oral. And I'm stating this only when we are not dealing with very scary condition. So per oral is better if INR value is not so scary and no bleeding or massive bleeding. And even the dose of 1 to 2 milligram, there's room for higher dose. But like I said, everything depends on the severity of warfarin effect or warfarin toxicity. Okay, it depends on the severity. So there's room for higher dose, but I'll get to that now. It could be given intramuscularly or subcutaneously also in few cases, but mostly per oral. Then there's room for higher dose of vitamin K, like up to 10 milligram. And that could be given slowly, intravenously or intravenous infusion. Okay? When there is severe bleeding. But per oral mostly, like I said, intramuscular is also possible. Then I need to state here, intravenously slow infusion in serious or severe bleeding. If you are by yourself, at this stage, please call 911. Or if you are the one to drive the patient, please head to emergency room. Even when you are giving your 10 milligram vitamin K intravenously IV infusion, whatever, just head to emergency room. The per oral, sometimes we can use the intravenous vitamin K, we can use it per oral. Do you get what I'm trying to say? You can keep the injectable formulation. You can give it per oral. So I hope this is clear. Let me quickly touch on this injectable vitamin K once again to make it clearer. We can give the injectable formulation of vitamin K per oral. Withdraw it, drop in the mouth of the patient, instead of giving it intravenously. We are running away from the possibility of hypersensitivity reactions. That's why. So instead of giving it intravenously, we give the injectable formulation per oral. The outcome is pretty close, though intravenous route is still faster. Here is the question. Someone asked me, can we give vitamin K1 prophylactically when someone is on warfarin? The answer is no, not at all. Either you agree there is no or not at all, we are still meeting the standard. No, we don't give it that way. Like I said, that vitamin K will be the first line when it comes to the use of antidotes in reversing warfarin effect. But vitamin K1 is just the first line. There are other agents that could be helpful. Like we can have plasma transfused, or we grab fresh frozen plasma. Tranexamic acid can be helpful. Prothrombin complex concentrate, or recombinant factor 7A. You can see that we have 1, 2, 3, 4, 5, 6 to make use of when we are faced with warfarin overload, warfarin overdose, warfarin toxicity. Oh, I remember. In all this, please contact appropriate people to help. Hematologists, clinical pharmacologists, pharmacists. As per the toxicity of warfarin, that will make that a separate presentation. Except when people accidentally, it might be intentionally anyways, ingest warfarin. We don't usually face, the toxicity of warfarin, but we have super warfarins that have higher potency than warfarin and have longer half-life than warfarin with more toxicity, and they are used outside humans. They are used as pesticide, rodenticide. They use it to kill rodents, mice, and bats that could transmit rabies virus. So, in case human beings will ingest that, I will have a separate presentation on that, but you can take this home quickly that we can give activated charcoal here if the person who ingested any of these super warfarins or warfarin is awake and conscious, and the time of ingestion and presentation is about an hour or less than an hour. Then we can use activated charcoal. If the bleeding is life-threatening, we can first of all grab intravenous vitamin K, then send a consult to the hematologist that, hello, here is a trouble, please help out. Then tranexamic acid and prothrombin complex concentrate. But like I said, it is controversial because of the probability of thrombus formation that could be deadly. You can grab your fresh frozen plasma or plasma transfusion. So I will have a separate presentation, but I have summarized what we can do in the face of toxicity with warfarin or super warfarin. Now, bridging. Remember that I've told you earlier that I'll be talking about this. Okay. Like someone is having active venous thromboembolism, DVT, progress to pulmonary embolism. The treatment will start with heparin, sure, with the mind of being on heparin for 5 days. We will start INR immediately, and we'll be doing that daily. We will then start the same person that's on heparin. The person will be placed on warfarin. On the second day that the heparin had been instituted or put in place. But some will say that they won't wait for the second day to start warfarin while still on heparin. They will rather start on the same day. Well, I think majority will still side with the fact that heparin from day 1, then warfarin from day 2. Then we'll continue until INR will be greater than 2 for 2 consecutive days. Meaning, both heparin and warfarin will continue to be going to the system of the same person until INR is greater than 2 for 2 days, then we'll stop heparin. Continue only with warfarin. Some people will then say nowadays that we won't even use warfarin for this purpose anymore. We'll rather go for direct oral anticoagulants for this purpose, for bridging. So they would rather use heparin with Xarelto, Eliquis, Radazza, or Lizano. So, in all, find out what the protocol is in your jurisdiction, please. Let us see. Have that robust conversation with your pharmacist, clinical pharmacologist, or hematologist. Crossing over. I'm not saying you are crossing over the bridge or crossing over to another country or anything. Someone is on warfarin, but we're now thinking that, okay, we want to stop warfarin, we want to be on another anticoagulant entirely, like Xarelto, which is a direct anticoagulant. Okay. First thing first, check the INR. Don't do it by yourself. Contact specialist, preferably hematologist this time, pharmacist or clinical pharmacologist, just to be sure you're doing the right thing, because one life lost could be too many. Then we have to consider the condition for crossing. Why do we need to stop warfarin? Why do we need to grab another anticoagulant entirely? We have to wait very well and explain to the patient. Or the patient is the one making the determination because the friend was on warfarin before, now on Xarelto. We have to weigh everything. Once INR is dropping to about 2 or less in most patients, and dropping to about less than 2.5 in those with mechanical prosthetic valves, then we can tell our hematologists, pharmacologists, or whatever that, okay, we have reached this level. We're now thinking to start this. Can we go ahead? Then at that point, you can embark on the use of direct anticoagulant, like the Varrozaban, which is Xarelto here, Avizaban, Dabigatran, or Edozaban. Maybe you're familiar with trade name. That is Xarelto, Eliquis, Radazza, or Lesiana, whatever. So, in pediatric age group, can we use warfarin? The answer is yes, meaning cautiously, be careful. You can use it, but you cannot use it in neonates. You cannot use it in too young infants, particularly those that have been breastfed exclusively. Remember, I've said it, the importance of gastrointestinal flora, bacteria, and the synthesis of vitamin K. All those will be lost in those that I've just mentioned, meaning a little dose of warfarin will have massive effect in them. Okay, because there is no or low level of vitamin K to antagonize. The target of INR in them will also be 2.0 to 3.0. The loading dose should be pretty low, as low as 0.1 milligram per kilogram once daily if the risk of bleeding is high. Okay? We need to do as if we're dealing with adults also. Liver function test, renal function test. Is this a child that is frail? Is this child very sick? Please keep warfarin off the table. Has this child undergone some procedures, lumbar puncture for meningitis, ruling out CSF, tapping, and other? No warfarin. Any surgical procedure recently? No warfarin, please. It is better to limit ourselves to 0.1 milligram per kilogram once daily initially. Then we'll keep our eye on, the right English word is keep an eye, right? On the value of INR, complete blood count with platelets. Even we are not treating the lab or lab results, we're treating human beings, right? focus on the physical state of the child. You know, they don't pretend. If INR is greater than 3.5, no warfarin. Take it off. But in all this, in fact, to even start, contact your specialist, contact pediatrician, contact hematologist, contact pharmacist or clinical pharmacologist. You know why? That young boy might be the next doctor or the next anything good you can think of. Don't mistakenly call the life shot. Now, side effects. Before reaching this level, you've known the side effects, particularly one major one that I've been talking about from the beginning. In hematology, we'll be dealing with bleeding, 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 bleeding. In gastrointestinal tract, there may be nausea, vomiting, or diarrhea, flatulence, bloating, and abdominal pain. The central nervous system can present with headache, confusion, and dysgeusia, that is, change in taste. Yes, Cushing trial can all happen with central nervous system. In dermatology, we can be faced with pruritus, itching, urticaria, dermatitis. Then bullous rash could be formed. Even loss of hair, alopecia, could be the case. We may be looking at ecchymosis petechiae, here. Then, purple toe syndrome. This is going to happen to someone on warfarin. This will occur suddenly, and it will affect the toes bilaterally. The lesions you're going to see will be painful and purplish, and you're going to find this on toes and on the side of the feet. But when you press it, it will blanch. The renal system could suffer failure, acute renal failure. And of course, in immunology, anaphylaxis and hypersensitivity. So is it wise to say you keep your EpiPen, Benadryl, intravenous corticosteroid all standby when you are about to administer warfarin for the first time in anyone? Since I have been emphasizing bleeding as this major side effect or complication of the use of warfarin, and let's go through what we're going to see as signs of bleeding. It could be minor or major, massive bleeding, could be concealed, hidden, that we won't say it, internally, or open, could be frank bleeding. So, what are the signs? Okay, go through this. Could be bruises. The gums could be bleeding. Urine could be bloody. The stool could be bloody. As a matter of fact, the nurses will tell anyone on anticoagulants generally that tell me when you poop, is either you ask me to say it or you tell me if it is bloody or not. So, bloody urine, bloody stool, joint swelling with pains when you are bleeding into the joints, petechiae or purpura, ecchymosis or hematoma, epistasis in those that are predisposed. When it is massive and concealed, there may be fainting attacks with dizziness and syncope. Then black and blue color, purple toes like I've explained. And when it is so serious, it could lead to hypovolemic shock, pallor, increased heart rates, shortness of breath, generalized weakness, confusion, drop in blood pressure, hypotension, cold clammy extremities. is no immediate intervention. Death. Drug-drug interaction. To those who are familiar with my channel, I will always skip this, telling you to contact your pharmacist or clinical pharmacologist because the list will be pretty long. Well, it's not that I'm doing something different, but there are certain things that we must touch with warfarin. Still contact your pharmacist, doctors, or clinical pharmacologist, but let's examine the following. Warfarin and vitamin K. If you are on vitamin K rich diet or medication and you have so much vitamin K in your system, you can decrease the effect of warfarin. Your INR will not go up, it will rather go down. And the tendency to clot will be higher. But if you are vitamin K deficient, then the dose of warfarin must drop because deficient vitamin K level means the effect of warfarin will be more pronounced, meaning there will be tendency to bleed. Vitamin E. If you're on vitamin E rich diet or vitamin E supplement and you're on warfarin, you are likely going to increase the effect of the warfarin and the likelihood of bleeding. If you're on certain juice, like cranberry juice, you may increase the effect of warfarin and you may likely tilt yourself into bleeding. Alcohol. So many people ask so many questions about alcohol. Do you know the best advice? Stop it. Just stop it. Because, oh, I don't, just stop it. Thank you. That's my best advice. Because some will say, will one cup, will one glass be fine, will be two glasses be fine, will be one bottle be fine, is it binge, is it chronic, whatever. The best for me is stop it. Monitoring. How do we monitor how well we're doing on warfarin? We look for one item only most of the time. Then later on I'll talk about this, okay? But mostly INR. Okay, how often should we monitor INR? Should we be checked? If you are in the hospital, right there, with the doctor and the lab people, we do that daily. You are not hospitalized. You're coming from home or from another community entirely. You need to drive and everything. Okay, depending on the proximity to the facility, to the laboratory facility, could be 1 to 3 days until it's stable and indeed the desired level is reached, particularly 2.0 to 3.0 in many people and 2.5 to 3.5 in those with prosthetic valves. Once the stable therapeutic range is reached, then you start monitoring using INR level every week for the next 2 weeks. So you continue later after weekly for 2 weeks, then continue as every 2 weeks for the next 1 month. Then you'll be on that monthly INR assay for as long as a year or 2. If you are stable all through, and you are complying with the medications and diet and other medications and everything, then you will not be measuring it every month. Once the INR is stable and you are not doing anything that is going to alter it, then it could be once in 3 months. Okay? But remember that complete blood count with platelets must be periodically acid, including renal function test, liver function test, even thyroid function test in individuals who had been diagnosed with thyroid disease in the past, or other parameters depending on the condition or conditions that warranted the use of warfarin in the first place. Now, warnings, not really warning per se, but just to take what we're about to say seriously. That is why we'll give it this type of caption. Remember the genetic constitution that has been addressed here. You can pause and reverse back that patients with those enzyme genetic polymorphism can have more trouble with warfarin if we give them certain dose like we give a Caucasian man or woman. So let's remember that not everybody could take similar dose under the same condition. False, particularly in elderly, even anyone that is on warfarin, whether elderly or not, if there's history of fall, then we have to take closer look at the individual and do appropriate investigations so that we will not be dealing with concealed bleeding unknown to us. Then all other medications prescribed or over the counter, including herbs, should please be disclosed to the doctor who has prescribed the warfarin. Why that? If the medications or herbs are capable of inhibiting the metabolism of warfarin, then we'll be dealing with bleeding. But if it is the other way around, that they will metabolize or enhance the metabolism of warfarin quickly from within the system, then we'll be dealing with clot formation unabated. Then there is an entity known as paradoxical thrombosis. This is the situation where we give the loading dose to warfarin naive individual, and the loading dose will do its work as expected to inhibit the enzyme that will activate vitamin K, and then in turn inhibit vitamin K dependent factors from having the capability to form clots, factors 2, 7, 9, and 10. But remember, it's going to affect proteins C and S as well. But the proteins C and S are the natural or endogenous anticoagulants that have been positioned to regulate the coagulation process. Now, with the loading dose of warfarin, those proteins C and S will also be affected. So it will lead to reduction in the level of protein C and S, or they become inactive. Therefore, the natural capability as endogenous anticoagulant is lost. Hence, thrombus formation will be the order of the day around that time that will give the loading dose. So that is paradoxical thrombosis in this case. Then atheromatous plaque emboli could be thrown by anyone that is on warfarin, please. Then vitamin K diet, if it is deficient or it is over, we know what that will be. So if vitamin K level is down, more effect of warfarin, more tendency to bleed, increased INR. if vitamin K level is too much high from the diet, or even supplemental given exogenously by the patient on his own, because no doctor will prescribe vitamin K supplemental with warfarin. No. But if the patient decides to take it while on warfarin, then the effect of the warfarin will become reduced and clot formation can continue. Then remember, gastrointestinal tract infection, you can pause and rewind. I won't waste your time to go into that again. Now, thyroid diseases. Thyroid diseases, depending increased thyroid functioning, like in hyperthyroidism, will lead to faster destruction of the liver-produced vitamin K dependent factors 2, 7, 9, and 10. And then warfarin effects will be increased, leading to bleeding. So in Graves' disease, in thyrotoxicosis, hypothyroidism generally, while the opposite will occur in hypothyroidism. So increased thyroid hormones will lead to increased warfarin effects, increased bleeding, then there'll be decrease the dose of warfarin will be necessary. If we don't do that in hyperthyroidism, thyrotoxicosis, or Graves' disease, if we don't decrease the dose of warfarin, then we are making the time to go to grave quicker for the patient. Okay, still on warnings. Before surgery, we have to discontinue warfarin for at least 5 days. Then we check our INR, and start warfarin 1 day post-operatively. But in certain pediatric age group, we cannot, I've said this before and I'm repeating it, we cannot give warfarin in neonates and not in infants that are too young. But let me be precise here. Infants less than 4 months, no warfarin. And any infants that is on exclusive breastfeeding, no warfarin, please. And also, I've said it, breastfed kids, right? Not in children that are on antibiotics for a long time, particularly per oral, because we need the natural flora, bacteria in the gut to help us in the production or synthesis of vitamin K. And that vitamin K will be helpful in determining the efficacy or none of the warfarin. But in well breastfed kids in clean environment will not have the natural capability to synthesize vitamin K because their gut may be devoid of bacteria. Then we should know that warfarin can weaken bones with bone marrow density reduction. So decrease in bone marrow density leading to fracture from falls. And now remember that elderly ones, either men or women, are predisposed to osteoporosis, particularly postmenopausal women, to osteoporosis. On top of that, they are taking warfarin. Can't you see that it's becoming double insult on their bones? So warfarin, one side, age determining osteoporosis with fragility fracture on the other side, and now we are not taking care of that closely, then a little fall, even without falling, they can have fracture. Finally, in children, there may be hair loss. So not all kids that have hair loss that have cancer and they are on chemotherapy. No. Children that are on warfarin for a long time will have hair loss, just like someone that is on chemotherapy. Finally, in conclusion, this is a very helpful medication that came from the pain of some farmers in US and Canada, but today has become one of the medications that have saved lives worldwide. Many times to those who took the pain to do research and where we are today. But as helpful as this medication could be, if not appropriately administered and followed and monitored correctly, it could be dangerous. It could be killing. Please, if you're on this medication, endure to comply. Use it as is prescribed. Now present yourself for INR investigation and all other investigations as your physician or healthcare provider would deem it fit. And to my colleagues, if you're confused, there is no harm in asking. Ask another physician, ask pharmacists, ask clinical pharmacologists, contact the hematologist, and as patient or physician, you can call 911 or edge to emergency room. It is better to do everything to save that life. Opening mouth to ask questions is not a crime. Closing the mouth and killing the patient is a crime. With that, I've come to the end of this presentation. Listening to me in the last 1 hour 57 minutes. Now, I've taken so much of your time, I appreciate it. But after this 1 hour 57 minutes, I don't think you have any reason or reasons to ask any further questions. In case you do, please drop the comment and share this with everyone across the globe. If you're interested, to translate this into another language, you subtitle it, please contact me. I will give you the permission to do so that you will not be getting any punishment for copyright or whatever. Thanks for listening. Please remember to subscribe, share it worldwide. I appreciate it. Let's save as many as we can from dying suddenly. I appreciate it.